about educating other staff members and becoming a champion and understanding stress related to working in healthcare. So what does recovery look like? And this was a question that I was asking a little bit earlier. What is there a end goal for recovery in your mind? When you think about entering recovery, what do you think? I just want you to challenge yourselves in your minds. What does that mean to you, and do you think that there's an end goal? Because I think it looks different for everybody. What are the treatment options for substance misuse? So, who wants to start out on the treatment options for substance misuse? Oh, we were still talking about that one.
Okay. So treatment options for substance misuse, I'll identify with that as far as there's lots of different options. And again, multiple pathways to recovery, right? Some people want to do abstinence-based programs. Some people will want to do inpatient treatment, like residential treatment centers. There's variations in all of that as well, as far as 30-day programs. There's faith-based programs. There's different levels as far as whether insurance will pay for different kinds of treatment. So we think of the top tier being detoxification, or now we call it withdrawal management, right? To be able to help people through that critical time. That's shorter term stays. Residential treatment centers, where it's more, we think of the traditional 30-day stay in a treatment program. Then there's also partial hospitalization, where people may go for so many hours a day. Intensive outpatient, that a lot of the, say, a DUI court or something like that might say, okay, they need to go to so many classes or go to so many hours in a week. Drug courts use that philosophy as well, kind of as far as they have to go to a group treatment for so many hours in a week to be able to do that. And then we have outpatient treatment. So I remind patients, and it's an outpatient treatment program, right? It's not coming in just to get a script written. We want to introduce them to our peer recovery support staff. We want to be able to connect them with counseling, besides what medications may be appropriate. And there's different ones that I think we're talking on a little bit later. But there's lots of different options depending on what the needs, finances, wishes of the patient is.
So, yeah, what is recovery? It's many things, right? Depending on who you ask. SAMHSA has developed a wonderful framework and has principles and key concepts for what recovery is, and this video kind of touches on it a little bit.
Okay, so we were talking about this just a little bit already when Dr. Martin was speaking. What is recovery? Strengths, responsibilities, person-driven, many pathways, holistic, peer support, respect, hope, addresses trauma, cultural, relational. So what I'm trying to get across here is that there's many different aspects to recovery. It's not simply just removing the drugs or alcohol from someone's life. Did you have anything you wanted to add to that? Okay. The pathways to recovery, Dr. Martin talked about inpatient and outpatient, the intensive outpatient. There's also so many paths to recovery. So I know 12-step is one that most people have heard of, so such as NA and AA, but there's also natural recovery where people just decide to quit using and they're just going to do it on their own. There's pharmacological, which is like MAT services that people can utilize, holistic-based, faith-based recovery, technology-based. There's a meeting going on online all the time. You can access a 12-step meeting online at any time. Mutual aid groups, recovery community organizations such as Divine Intervention, peer-based recovery, and relapse prevention. Recovery is not linear.
I just want to make sure that we know that recovery is not linear, right? So, and relapse is not failure. We had another great video from the University of Wisconsin explaining, and a lot of times how sometimes physicians take it, kind of take it personally, that they're the ones failing. They relapse and they come back like they did something wrong. You know, it really has nothing to do with that. At the very least, maybe that bond wasn't created, or the relationship wasn't founded on trust. But if they're not ready, then they're not ready, and that's got to be okay. For people that just want it to get done and moving on, kind of, which especially in the ED, I would think, fix one, go to the next, fix one, go to the next. That's not what recovery looks like, and it's hard to accept, but that's got to be okay.
And to, excuse me, to know they may come back several times to your emergency room, and that doesn't mean that they don't want help and that they don't want to be in recovery. It just means they're struggling with their illness right now, and we have to help them look for alternative ways of treatment.
Just a quick question for the peers in here. Did any of the peers get sober after their first attempt?
No.
None? Right. Or the second, or the third. But look, we're here.
I think it was 4 for me.
Just wanted to throw that out there. This is the video that wouldn't play.
You can skip that.
Yeah. Ooh. Harm reduction. All right. So this can, we touched on it earlier. This can definitely be a sensitive subject when you're speaking about it. Again, there's a few different definitions. SAMHSA describes it as an evidence-based approach that is critical to engaging with people who use drugs and then equipping them with life-saving tools and information to create positive change. I think that's an important aspect of that, is creating positive change. That might not be sobriety, right?
So I hear about this a lot, particularly as somebody who prescribes buprenorphine, right? And one of the things that I point out to people is if I can't continue to try to stabilize somebody to keep them alive through whatever harm reduction means, right? A patient may come in and 7 times ask for naloxone, right? It may be,
No, it's mine.
Are you there? Hello. It may be repeated times that we have to work with somebody and we try to figure out what that barrier is, or using buprenorphine or different things like that. But if we don't employ some kind of approach, then so many times we will not have that person be alive long enough for us to do any kind of reduction. So again, being able to put aside some of the biases and different things like that as far as the harm reduction models and options, I think is really important.
And it's also, as it says, it's a strategy, it's an approach. It could be an organization, it could be services. Harm reduction is a very broad term that can mean a lot of things.
I also think, and I was just going to say, harm reduction, that's a big word and it's a big concept. And I'll say I've been in a lot of webinars and I've been in a lot of trainings, and I still struggle sometimes with the concept. And finally, I had to break it down into reducing harm. And so thinking about how to reduce harm when someone presents and they're struggling with a substance. And so for me, that's kind of how I've broken it down. And so it's all of the things that we've talked about. But it can even be education. We talked about clean syringe exchanges, education, naloxone. But just helping know that if harm reduction just doesn't make a lot of sense initially, some of these concepts are complicated. So I want to put that out there.
And I just say this from the peer perspective, Dr. Martin really touched on it, was harm reduction for peers is kind of tough to swallow sometimes, because is someone really in recovery or is someone really not in recovery? But when it boils down to it, for us in the simplest terms, is if they're still alive, they still have a chance to recover. And that's the way we have to look at it as peers. So the peers that are going to be in EDs and clinics, that's the philosophy that we take. Whatever they choose, as long as they still are alive to make that choice, that's what matters. So,
but yeah, just to touch on Sean's remark, sometimes for like people who are in recovery for abstinence or like with abstinence, it's harm reduction's a hard pill to swallow. I've had to educate, just since I've been, the last couple of years doing what I'm doing, I'm like, I did not love harm reduction. I'm gonna be honest, because I think about handing out syringes, and I just don't see how that seems almost enabling. So I've had to educate myself quite a bit. Yeah, go ahead.
Well, I was going to say that a lot of people look at buprenorphine and Vivitrol, naltrexone, methadone as the same thing, right? They have a very difficult time with that being a form of harm reduction because they say you're just replacing one opiate for another. In fact, the drugs are different. While it's still an opiate, there's a difference, but it allows that opportunity for people to be able, like you said, to be stabilized, right? We would not let somebody walk out of the emergency room with a blood pressure over 200 or heart rate of 150 or whatever. What do? We give them a medicine to stabilize them, right? We get their blood pressure down. We give them something to control their tachycardia or their atrial fib. We would be considered negligent if we didn't, right? So that's how sometimes we have to think of, or I encourage people to think as far as harm reduction, is that we're trying to stabilize through different means that opportunity for that person to make it to the next specialist or to the next recovery process so that they can get the help that they need.
So why harm reduction? This kind of shows by year, every year, overdose deaths. Starting in 2019, you can see every year it just keeps growing and growing and growing. We're not reducing those numbers. So something that we're doing is not right. We've got to try a different approach because they'll keep climbing if we don't. So this is some of the benefits of harm reduction. It prevents disease and transmission of diseases. The cost savings you can see at the bottom, which I think Sean touched on a little bit earlier, but it generates healthcare cost savings. For every $1 to $2 spent in harm reduction, $5 to $7 is saved. So that right there is kind of seems like a no-brainer. It provides an entry point. Again, just a chance to plant that seed with somebody, right? They might not be ready, but it allows people to reach those populations that might otherwise not be served. Reaches vulnerable populations, kind of the same thing. We went over a few examples of harm reduction, the MAP program, naloxone, overdose education, drug checking education. There are these little strips that people can get to test their substances to see if there's fentanyl or xylazine in them. And again, I can see why people would think that would be enabling, but at the end of the day, harm reduction is just about reducing harm, right? So people are going to use substances whether harm reduction is there or not. These services or this approach just keeps them alive and a little bit healthier, a little bit longer in hopes that, they'll take the journey to recovery.
Yeah, so medication-assisted treatment, we now call it MOUD for medication for opioid use disorder. So you'll hear that as well. It's a comprehensive evidence-based program that is utilized in order to help people break free from their substance use disorder. it's been researched for some time. Methadone's been around for a long time, but the more common one that we find and access to and things like that is buprenorphine, also known as Suboxone. There's also now Trexone, which is not naloxone, not the nasal spray, but the oral tablet or the injection Vivitrol, which blocks opioids, also works for alcohol use disorder and for some people for stimulant use disorder. It's non-addictive. There's different formats and ways that it can be used. And medication-assisted treatment is actually available for not just opioids, right? We hear, oh, that's a Suboxone clinic. Kind of like a biased label, but there's actually medications that help with all use disorders, right? Even methamphetamines, we know that Wellbutrin can be used for some patients to help decrease cravings. Good old Remeron being used, it's the only FDA-approved drug to help with cocaine use disorder. Pretty sure they didn't talk about that in the past, but there are these options and solutions, but it's not just prescription plans and things like that, it's incorporating the whole program, having peers involved, having therapy involved, encouraging meetings and things like that that allows for that. And just to touch real quickly on the fentanyl strips as far as testing, understand that that's a lot of times used for people who have methamphetamines, who their methamphetamines or other drugs are being tainted with fentanyl, which is causing a lot of the overdoses. So that's part of the reason why they're suggesting that, if that helps make better sense, because sometimes that's unclear. Yes, Jenny? You know, I've been told if I figure out that one, that I will be a millionaire. So there are not necessarily protocols in place for that yet, but a lot of times for cannabis use disorder therapy, and there are a lot of people, if you find out why they use the cannabis, right, it really goes back to, I have anxiety, I have insomnia, I have trauma, and so for me, I treat their underlying use disorders by getting to what they're using it for, right? Whether it's pain, anxiety, trauma, different things like that. But there's no official FDA-approved drug for cannabis use disorder.
And Dr. Martin made a good point with the MAP program. A good MAP program allows for the medicine is just one part of the equation, right? A good MAP program will have the therapy services. The medication is kind of still putting like a Band-Aid on it, but why did they start using or to continue to use? So that's when the therapy and peer support really goes into play.
Thank you, Misty. And I hate to call anybody out, but I wanted to ask Boston Mountain. We've got Julie Carmen and Sadie Davis here. I know y'all are visiting about something really important, but I wanted to ask if you could just quickly describe your MAT program and the different components, because it's a really successful program. They have 15 total sites, but we've been working with them and we have watched their MAT program grow, and they are doing amazing things. So we want people to hear about this resource.
So if you want to know like the details, call Sadie. But I'll give the overview. She makes the world go round for us. But as far as our program, we do have a very holistic program, or at least what I feel like is, and we're always looking for ways to expand or grow the program. We do provide the medication-assisted treatment, but typically it doesn't start with that. It starts with just really a complete assessment of when a patient comes to us, whether they're sent through the court system, through a peer group, wherever they come to us from. And we assess their social determinants of health, connect them to resources, we look at their housing, all those different things, try to connect them to peers. That's something new that we're kind of in the process of, so we're very new and not very good at that yet. So, but also just connecting them with 12-step groups or whatever modality. There's other things like CR and Smart Recovery and a couple of other groups that we recognize. And then really when they call with an interest, they're given the program requirements up front. We're big on teaching them accountability and boundaries. That's part of our program. We should model that. They should follow kind of through with that. And so they're given the program requirements before they even decide to say yes, they want to make an appointment. When they come, they're told the program requirements multiple times, so there's never any like vagueness or ambiguity about what's expected of them. We try to be very clear with that. We do a behavioral health evaluation, so they meet with one of our psych providers for an evaluation. They also see a therapist, and then we screen them for legal aid. We do have a partnership with legal aid, and in some of our clinics, the legal aid lawyers will actually come on our MAT days, and then the patients can actually meet with the attorneys and have their MAT services and get everything done. And we do provide transportation. What else am I missing? We have dental services, so we can help with them with getting some dental issues. That's something we see common. We do have a slide fee scale, so if they don't have insurance, we do have a slide, and they can sign up for that, and they can have a PCP appointment, lab work, and a whole bunch of other stuff done for under $10. There's a lot of Northwest and North Central Arkansas.
So like you say you provide transportation, how many miles? That's a great question.
That's a Sadie question.
I think the closest clinic Cersei would be Conway.
The Conway would probably be Quitman, maybe. And then we also have care managers. So on the team, we have a MAT prescriber. There's a therapist. Our therapist is LDLAC certified, so she knows what she's doing as far as that goes. We also have care managers at our different locations, and they're really, I call it like the boots on the ground. So they coordinate with the patient. The patient's call, I'm struggling, I'm having a hard time. They'll assess what are you having a hard time with exactly, and let's kind of figure that out, and then say, okay, do we need to get you in with your behavioral health provider? Do you need to have an extra therapy appointment? Do you need to see your MAT provider? What exactly, where do we need to kind of send you and get you? So they do a lot of that resource, because sometimes patients will call and they're just like, I don't know, I'm just having a problem. And when you're in recovery, that's, you need someone to help you figure out what's happening and be able to put words to that. So that's really where our care managers are. And, well, is it, I haven't slept in 3 days. Okay, that's a good start. Let's start there because you need to sleep. So sometimes it's just that simple of figuring out exactly what's going on and just trying to help connect them to resources.
And I think that's probably been part of the question for us as far as peers go is like our care managers kind of act in that way.
But they don't have lived experience, and that's really where
So it's kind of just figuring out where that fit in and everything. But this is all part of their primary care. It's all under one roof. So that's super beneficial for a lot of folks. A lot of our places are super rural. So it's just necessary that we have everything under one roof. And, we all do a lot of telehealth stuff.
we do. We have an OBGYN, so if they're pregnant and they need MAT services, we can provide that, and we can provide OB care up to 28 weeks. And so that's helpful, all in one location. So for people if you think about people that are just getting into recovery, there's so many barriers, at least from what I see, that it's kind of like I really identified with what you're talking about. It's like, where do you even start? So we certainly don't walk for them in any way. They have to walk their own recovery, and we certainly, I don't have lived experience. I can't offer that insight to them, but I can say, let me help you figure out what's going on, and I can help facilitate for you to get what you need to get and maybe connect you to someone that can help you. And that's really the thing. That's their choice if they want to follow through with that. I don't make them do that. I'm not in charge of that, but I can facilitate and I can be there. And one of the things we tell them is keep coming back. If you have a slip, something happens, don't make that be something that keeps you from coming back. Come back, tell us. We'll sort through and assess the situation. What exactly happened? Let's go back and figure it out, and let's figure out if something could have been avoided, or if you could have done something differently, or if we could have done something differently, or if something different could have happened. And then let's kind of make a plan so that if you get in this particular situation again, you know what to do, and it doesn't evolve into, an additional problem. So that's one of the things we tell them is just keep coming back, keep coming back.
So I was going to speak to your question and stuff like that because I have outpatient, of course, integrated healthcare and stuff like that. For me as a provider working in that space, I use the peers anytime somebody comes in for an evaluation, and whether they have a substance use misuse issue or mental health, I'll ask them, part of our program, first thing I want to do is I want to take you over and I want you to at least meet my peer recovery support specialist. Where it goes from there is all up to them, and they can decide, but be able to get that card, know that connection and stuff like that. And I use them for naloxone training because every patient that comes in also gets naloxone training. So allow for them to do that, and that helps open up those conversations. Yeah, so no matter what they're there for, I say, oh, let me introduce you to the team. Just know that it's available, right? And so,
Absolutely.
yeah.
Well, and
I normalize it. There's a peer that you should know, and that's a part of the medical team at standard.
absolutely. And that's part of the culture shift.
Can I add to that too?
Yes.
Talked about. Okay, so I was the first one that started out in the Northeast region, right? And so when I started getting a team, it was so much better with a team of people because I was only one person. And so it was so much better to build a rapport with my whole team because when I wasn't there, they was able to take that place. You know what I'm saying? So it just worked out hand in hand. Like I don't have a social worker yet, but but I referred them out to them. But having a team was just so much better because it took a lot of the pressure off of me.
Absolutely. And I think it's so important. And I'm so grateful. Thank you, Julie and Dr. Martin, for you all to share a little bit about your programs and your experiences, because it's one thing for us to come up here and talk about, well, this is how it looks, or this is what the literature says. But these are real practices in Arkansas, and this is happening. And so we want you to hear firsthand on this can happen in your community, and this can happen at your site as well. So thank you.
I'm Christy Hall, and I'm an advanced peer specialist here at River Valley Medical Wellness. My role here is pretty much with the MAT program, and I do a lot of mental health as well. Where it's just everything's individualized, so it just depends on what they need. But I love my job.
I'm Tommy Simmons. I'm a peer support specialist working at River Valley Medical Wellness, advanced in training. My role here is really whatever they need me to be. But in the context of peer support, I advocate, I work with people, ask questions, try to find, that hero inside that person and try to help them, bring that to light and be the best version of them that they could be.
So in the context of recovery, MAT is something I have lived experience with. I don't think I would have been successful without it. It was a part of my early recovery journey. It looks like us being that bridge to the provider. Between the provider and the peer, we can connect on a different level because we have that lived experience, right? It's important. What do you think?
I mean, MAT is a path to recovery. It is a path of recovery. There is stigma around it, of course, which we work, every day as hard as we can to break that stigma. But it is a pathway to recovery, and I have seen success in MAT. From what I can see, people come in, and a lot of times when the peers come in, they're scared. It's a very daunting task to come into a clinic like this anyway. And most of the time you're feeling bad, you're feeling sick. Life has rattled you for quite some time now. So whenever we get someone in, we work with them, we talk to them. And it's the little things, so instead of saying like, here's your medication, good luck with all these things, because we do have an outpatient program and there's meetings involved and there's, there's appointments we have to make, which I could tell you whenever I started in recovery, those little things were terrifying to me because I wasn't used to doing that. So, talking to the peer, finding out what they want, but also just helping them kind of be that bridge, get them started in that process, because once you make the first couple of appointments or you actually bring in a meeting sheet and it's signed, that empowers somebody, that makes you feel really good. So we walk with them through the process instead of just letting, like, hey, do this alone, have fun figuring it out. We don't let that happen. We work with them.
There again, it's individualized. So we just take whatever that needs assessment is for the individual. Initially, usually that first appointment, we try to start working on things. Like Tommy said, sometimes it's not possible because of them being sick or overwhelmed with that first appointment. So it's just person-centered. What are those needs? Okay, let's come up with a plan. What are your goals? What's your purpose? I don't know. Okay, let's figure that out. I'm here to walk with you to figure that out. One girl that's coming to mind, she came in very broken. I remember working with her, and the fear, right? The fear, that desperation. And now to see that journey and to see her successfully living her life, being a productive member of society, working, enjoying life, and seeing that peace in their eyes. Yeah. And it is an ongoing journey, but that is, that reward is why we do this job, I think. Yeah.
Remember seeing the first day, I can remember it. I identify with it, coming in, head down, feeling awful, and in an environment that is new and foreign, trying to take a step toward it. And really, you're taking a shot in the dark because you don't know what it's going to be, what it's going to look like. So, it takes a lot of courage, being scared of something, but still like, hey, what I'm doing isn't what I want to do. And seeing that first foot take off and just hasn't let off the gas since. Everything in between, as far as our outpatient program, with what they needed from the provider, and just have, life just being revigorated, and seeing that process is amazing.
Part of what we do, our job, is to educate, but in a loving way, not in a, point the finger type way. We just do our best to be that bridge again, and to use our lived experience. A lot of people tell me, well, you don't look like you were ever on drugs or whatever. Well, yeah, I was in active addiction at one time, and my life looked very different than it does today, right? So being that example, being that role model, I think it helps people see the end result, what it could be, right? Yeah, stigma is a hard one. I think it's going to be a constant battle for a while. Yeah.
I think what helps me the most with advocating against that stigma is I was someone who stigmatized MAT at one point in my life. Through my recovery journey, the circles I was running in, the conversations were being had were very much stigmatizing against MAT. Being able to come here and work, when you see the evidence that something is working day in and day out, you physically see, and you get to witness, and you get to work with people, that becomes concrete. So I don't have to try anymore. I just have, I just convey to people, like, we are seeing this every single day. The evidence is there. I think it takes a perspective change. Somebody maybe just, the honesty, open-mindedness, and willing part, become open-minded, actually look at the evidence in front of us that this is working. And like she said, it's easy to become disheartened. And I think it's easy to become angry. So as long as, it's our responsibility to convey ourselves, not like, hey, look, this is working, but still react in a professional manner, and understand that some people just haven't seen the evidence, but we want to give them the opportunity to see that, because once you know something, you know something.
My name's Kayla Logue. I've been in recovery for about 10 months. My drug of choice was opiates mainly, and methamphetamine. I really had to make myself come in here. I was very stubborn about it, but I knew there was a better way to live. When I first learned about it was when I was in rehab in Hot Springs in 2019. I was offered MAT, and I refused it. Don't know why, I just did. Didn't think I needed it at the time. And from then on, I just stumbled, relapse, got clean, relapse, got clean, and finally decided to come here. Suboxone saved my life. That's really all I have to say about Suboxone. It's wonderful. It saved my life. It made it to where I had no cravings. I could function normally in day to day, whereas before I couldn't. And everyone's so nice here. All the peer support has just been wonderful. It's been paramount to my recovery. I've had people, I've read many things online, saying if you're on Suboxone or if you're on any kind of, MAT, that you're not clean. I've had people say it to me personally. But considering all the things that I was on before, yes, I am clean. Talking to someone without having a biased opinion about your life really helps you to open up and dig down deep into stuff that you wouldn't normally talk about, even with your family. Because it might take a few sessions, it might take 15 sessions, but eventually you will get to the source of the problem that you had whenever you started using. I don't think that we could connect on the same level if you were speaking to somebody that had no idea what you were going through. First, don't listen to the stigma. Read on it, educate yourself, and tuck your pride away. Just do what you need to do to get healthy and to live. Peer support, because I always have somewhere, a safe place to go to speak to someone about whatever it is that's bothering me. And as far as recovery, I see recovery for life. I see being clean for life. And without Matt, I wouldn't have been able to do it.
But that speaks to the work that's happening in your clinic, Dr. Martin.
Right? Whenever people say, oh, I don't need any of that, I don't have an issue. Well, it may not be you. It may be a child that's in the home. There may be a grandkid that picks up one of granny's hydrocodone and doesn't realize what it is. There's all kinds of different reasons to have naloxone available in your car, in your house, anywhere. And so literally, it can't save a life if you don't have it available to use. And that's what I tell people that say, nope, not me, I don't need that. Okay, well, can you give it to somebody else in your sphere or circle that might be able to use it again? And I haven't had anybody that's turned it away.
I also want to say our HRSA project officer provided us with some education just the past couple of months. And one of the things they said is there's been a big push for naloxone. We've been giving a lot of naloxone out, and it is expiring. And so I think, I can't remember what the shelf life is. That's not my area. I'm not the pharmacist. Okay, Dr. Martin is saying 2 years. But one of the things that HRSA wants us to know is even though it says it's going to expire, it may be good for 2, 3, 4 years. So don't throw that naloxone away, even if it is expired. They have pushed a lot out across the country, and they want us to know, even though it says it's expiring, it's still good, and keep using it. So I did my job.
All right, so finalizing a little bit about harm reduction, some of the myths versus the facts. Harm reduction encourages people to use drugs and enables risky behavior. Like I said earlier, people are going to use drugs with or without harm reduction, right? It offers an opportunity to engage with those people who struggle with substance misuse. It gives them a place to come, like that we just heard from that patient, that is judge-free, right? Harm reduction opposes recovery and abstinence. Again, that's ridiculous. Harm reduction doesn't encourage or, what's the word? Oppose abstinence, right? Because again, it is the patient's choice. It's patient-centered. So we kind of go where they go. We don't push it down. If someone wants to do complete abstinence, awesome. Recovery, great. But harm reduction is not going to encourage one way or the other. Harm reduction is only for people who use drugs. Megan touched on this a little bit earlier, right? There's from seat belts, condoms, designated drivers, all harm reduction services.
Okay, how to be a champion. We also touched on this a little bit earlier. We need someone from your organization to be a champion for implementing the peer. So the reason we need that is so that you can educate and train the other staff members to understand all the information that you've learned today. And even though it's been a lot to take in, you can give them the basics and you can be that advocate for the peer in your facility. Okay, so let's go over some of the details here. Peer specialists should report out positive patient outcomes following hospital discharge and help ED staff understand the role in achieving positive outcomes for patients. Avert organizational culture clash. Identify effective leaders, team members who are passionate about integrating peers into your organization to help you champion the cause. and addresses concerns early, ask questions often, respect role boundaries, and speak person first language and provide a patient centered culture. So it's about being the change in your organization and being the representative for that peer. Orientation is going to help. So you're going to have a way to orient your peers into your facilities. And we've talked a little bit about this. And we're not giving you this information and dropping y'all and saying, okay, go hook up with the peer. We're not going to do that to you guys. We are going to actually probably set up Zoom calls with you each facility to talk to you, introduce you to the peer that you will be working with so that you will get to know them. We can start talking through processes. We can start talking about the hours they will work, how will they work into your workflow, and things like that. So don't think that we're just going to give you this information and walk away. We're going to hold your hand through the process.
But the peer who is assigned to your site as well.
Yes, Sean and I will continue to help be supervisors for the peer that goes on site.
I will say, as part of the orientation, I think it's a huge piece to introduce the entire team to the peer, right? They're not going to refer or do a warm handoff to a peer if they don't know that the peer is there. So I think part of the orientation process, I think it's very important for the peer, even if it's on their own, go around and kind of introduce themselves so that people know they're there.
Absolutely. Just because they're not hired directly through your facility doesn't mean they can't be a part of your team.
Just one more thing in there, just is, and if you have providers, physicians that are resistant or want some more instruction on how to do that, because I know that sometimes we are the problem, right? I mean, as far as resistance to change or implementation into something into a hospital, and we say, oh, we don't have time for that. Call us, let us know. I'll be happy to talk to any of them about my experiences and how it can save lives, of course, but also help save time and really connect people better if you have any of your providers or people that want information as well.
Yes, I'm so glad you're saying that, Dr. Martin. And as part of this project, if you can't connect with Dr. Martin directly, connect with someone on the ABIN team, and we can try and coordinate something so that we can get some education to them.
Yes, we're an added resource. The RCO, Sean and Megan, ABIN, that's what we're here for. Like I said earlier today, we want this to be a success. So we're trying to give you as many tools and resources at your disposal. So please use them.
All right, stressors in healthcare. We all know working in healthcare, there's a lot of stress. We've talked a little bit about that. And just want to talk about what are some of the stressors. Well, some of the stressors are working with patients and seeing some of the things that come in, right? When someone does die of an overdose, when we do lose someone, that's extremely stressful, and that affects us and that stays with us. It doesn't just turn off at the end of the shift. So I think that's really important for us to remember. Staff shortages. We, as we talked today, even preparing for today's training, it's difficult for people to take time away from their organization to come here. We know that there's not adequate staffing. So one, thank you all for being here today. But it's really important. And, especially during COVID, one of the things that we heard is it was critical, and we were having to make really difficult decisions on health issues. And so we know that. We know there's a staffing shortage, and not just in Arkansas, but across the country. Compassion fatigue. We're working with people all day, every day. We talked about we have to show up, we have to be present, we have to be listening to them, we have to establish a trusting relationship, we have to establish rapport, and it's hard. It's hard to be empathetic all day. And I probably shouldn't be saying that, but it's the truth. And so I want us to know it takes a toll on each of us. And so as we've mentioned earlier, none of us are immune to that stress. And we have limited resources. One of the things we hear is one of the biggest stressors for healthcare professionals, is that when someone can't provide adequate resources or they don't know where to refer someone, it really takes a toll. And so that's important to know, especially as we're rolling out a new program. Next slide. Okay, self-care. So when we're thinking about self-care, I know we don't have tons of time today, but I think it's really important to have a wellness plan, right? If I asked you to raise your hand if you have a wellness plan, do anybody in here have a wellness plan? Yeah. Ah. No, I was using that as an example, Misty. But what happens in the healthcare profession is we're always taking care of everybody else, right? And so I think that's really important. I laugh because how many times do I have people on my team who are coming to work sick, and I'm like, hey, didn't you just have a surgery? Didn't you just have COVID? Whatever else is going on. Why are you here? And it's because we're used to taking care of everyone else, and it's really difficult to sometimes pause and pay attention to ourselves. Okay, so here's some pillars. I'm talking a little faster now because I know the time's going by. We got physical, emotional, psychological, spiritual, personal, and interpersonal, and professional. And so one of the things, the Whole Health Institute over in Northwest Arkansas, they did a fantastic job training us on really wellness. And one of the things that I think for me that I have taken away from that is when we're thinking about self-care, when we're talking about physical self-care, paying attention to our body. I was talking to a physician once and they said, our body whispers, and those whispers are warning signs, and we need to stop and we need to listen and we need to pay attention. It's really important. Whenever I think about physical as well, one of the questions that I ask myself when I'm working with people is, have you had any movement for your body today? Doesn't matter what type of movement that is, but movement is really important for our bodies. And what does that look like for you? One of the things we know, there's a link between physical activity and anxiety and depression. And so we know if you can have 45 to 60 minutes of brisk cardio activity 5 days a week for a 6-week period of time, we start to see the same benefits as if you were taking an antidepressant or an anti-anxiety medication. Good article just came out this week that was supporting that. So we hear that all the time, but do we have time to do that during our busy lives? I'm going to speak for myself, not all the time. Y'all don't have to tell me. Okay, emotional. Are these energizing relationships that you're involved in? That can be with your family members. That could be with significant others. That could be with your team members. Or are these toxic relationships? Are they depleting your energy? Are they causing you stress? Something really important to pay attention to. Psychological, spiritual, personal, interpersonal, and then professional. I also think, we don't have it listed on here, but really, our physical activities, food and drink activities, are we eating and drinking things that are healthy for our bodies? How is that affecting us? Pausing, one of the things I laugh, I see a lot of us are walking around, we have these smart watches or smart devices. When I wake up in the morning, one of the first things it says is, take a mindful moment, pause, think about yourself before you start your day. I mean, we're all laughing, but before we start the chaos, it's really important, and these are the ways that we take care of ourselves. So please pay attention to that and consider developing a wellness plan. Next slide. Oh, look at this. Okay, we've got them broken out. One of the things I love on here for under the emotional is be selfish once a day. I love that. I think that that's important. Take compliments from each other, practice acceptance and forgiveness, relaxation techniques. These are critical. Take a couple of minutes every day. Pay attention to, thoughts, feelings, attitudes. What is your body telling you? As I said, our body and our mind are really going to send us signals. If we are getting fatigued, if we're getting exhausted, pay attention, take a break, maybe go outside. I was listening to something the other day and it said, get in touch with the grass. And I thought, oh, wow, that sounds so simple, but it can make such a profound effect on us.
Next, looking at the sewing, like that's, I don't think anybody's ever watched me sew because that is not very, that's not, that would not be relaxing to me.
That wouldn't be soothing for
No.
Misty. All right. One of the things on here we have for spiritual, we've got understanding our authentic self, try meditation, yoga, read, prayer, whatever that means to you. Making this personal. Again, I think a key takeaway is what works for me probably isn't going to work for Misty, probably isn't going to work for Megan, probably isn't going to work for Julie. And so we all have to pay attention what helps us. Next slide. Okay. Think we have time? Well, we we have just a mindfulness activity that we could walk through. I think we have time. I think it'll just take about 5 minutes or so. So I'm going to go ahead and just ask you to spend a few minutes with me, pausing, taking care of yourself, and being intentional, being mindful. We've got the sirens going on. But we want you to begin by making yourself comfortable, by allowing yourself to switch from your usual mode of doing and being busy and having a busy mind to really doing nothing and simply being. I'm going to invite you to close your eyes if you want to put your head down, whatever you'd like to do to feel comfortable. We want to connect with our bodies and we want to bring our attention to our breathing. I want you to follow your breath as it comes in and then out of your body without trying to change it. Simply be aware of your breath and any feelings associated with it. Give full attention to each breath and then to each breath out. Being totally here in each moment with each breath. If distracting thoughts arise, acknowledge them without becoming involved and then return to your breath. Take a moment now to consciously set an intention for this practice. Some examples are to open my heart, to cultivate loving kindness, to care for myself. Bring to mind a person or a pet for whom you're happy to see and have deep feelings of love. Imagine or sense this person or pet, noticing the feelings you have for them and how they arise in your body. It may be a smile that spreads across your face. It may be a warmth in your body. Whatever it is, allow it to be felt. Let go of this person or pet and continue to keep in awareness the feelings that have arisen. Bring to mind now and see if you can offer loving kindness to yourself by letting these words become your words. May I be safe. May I be happy. May I be healthy. May I live in peace no matter what I am given. May my heart be filled with loving kindness. Notice the feelings and sensations that arise and let them be. Now try offering loving kindness to someone who supports you. Bring that person to mind and let these words become your words. May you be safe. May you be happy. May you be healthy. May you live in peace no matter what you are given. May your heart be filled with love and kindness. Now notice the sensations and the feelings that arise and let them be. Once feelings for a loved one flow easily, turn your attention to someone with whom you have difficulty. It's best not to start with the most difficult person, but someone who brings up feelings of slight annoyance or irritation. See if you can let these words become your words. as you keep this person in awareness. May you be safe. May you be happy. May you be healthy. May you live in peace. No matter what you're given, may your heart be filled with love and kindness. Notice the feelings and sensations that arise and see if you can just allow them and let them be. Now bring to mind the broader community of which you are a part of. Imagine your family, your colleagues, your neighbors. Fan out your attention until you include yourself in this offering of loving kindness as you let these words become your words. May we be safe. May we be happy. May we be healthy. May we live in peace no matter what we are given. May our hearts be filled with love and kindness. Notice the sensations and feelings that arise within you. Sit with them for a few moments until you are ready to open your eyes and end the practice. What was it like to just pause and connect with your body and pay attention to your breath and your thoughts? And do you feel any different now than when you started?
I did feel more relaxed and a little bit more, not so uptight and rigid.
Thank you, Misty.
Mm-hmm.
I appreciate that. I'm joking because, sometimes I'm not doing what they ask me to do. But I think it's really important, right, that we pause, that we pay attention to ourselves, to our breaths. And I think it's really challenging, and it can be difficult. I can tell you sometimes, and just thinking about, working in the healthcare setting, I don't know, your shift starts at 7. I can say this because I have a daughter who's a new nurse graduate, and she's working on med-surg, and, shift starts at 7. It might be 3 or 4 p.m. before she's sitting down to have her lunch. Is that unusual, Dr. Martin? In the healthcare setting, we see Dr. Martin walking around. She's got her Rockstar, and I know she's emailing sometimes at 3 a.m. Because she's running around. She's busy, she's working, and she's busy taking care of everybody else. So it's really important that we pause, that we take care of ourselves, that we check in with ourselves, that we manage our stress, because we don't want to struggle with some of the health issues that could arise from stress.